So I think the next thing to chat about is phosphorus. One of the things that really came up both from my peers, from my own research, is that there isn't really a systematic way necessarily to replete phosphorus. And I think this is for a couple different reasons. Part of it is that you just don't have the same dose response relationship that you have with potassium. And then on top of that, repleting phos is tricky because you have these kind of like combination PO agents like Nutrifos, you have pure phosphorus, you have IV phos, which comes with its own sets of challenges and takes forever to run. Like, how do you think about repleting phos?
If you just start with what our goal is in terms of numbering, we're not aiming for mid-normal values. I typically see people begin to create that checkbox for replete phos when the value gets below 2.0. But the lower limit of normal for most labs is around 2.5. So unlike potassium, where we're aiming for a value above the lower limit of normal, for phosphorus, we're aiming for more normal. And the idea of trying to get someone back to a normal range seems like a justified thing to do, with, of course, the caveat that the evidence for doing that is scant. Phosphorus and magnesium preparations can both cause diarrhea, and so there can be some inconvenience, undoubtedly. It's worth just making one point about Nutrifos, because I think one that many of us are familiar with. An intern should get comfortable with what their local hospital oral phosphorus preparation does. And the reason I bring this up is most of them contain potassium. Now, the potassium that's contained in Nutrifos, most preparations, is only on the order of 10 to 15 milliequivalents. But if you've got a patient who's got a potassium of 5.7 on their morning labs, you probably don't want to give them even 10 milliequivalents of potassium. But I think the listeners should know what they're giving their patient. They're giving them phosphorus, yes, but they're also giving them sodium and they're giving them potassium. They want to know how much of those things as well, because it can be something more than just an innocent bystander.
I'd love to get your framework for how you think about someone with hypophosphatemia and what could have caused it.
So with hypophosphatemia, you can get GI losses. The losses are often mediated by PTH. I don't typically think about even hyperparathyroidism as causing hypophosphatemia. It just might cause low normal phosphorus. The more severe hypophosphatemia that I have seen, except in maybe that patient with alcohol use disorder, are these patients with shifts. The patient at DKA, for example, who have massive of phosphorus into their cells, or refeeding syndrome. I think those are the scenarios where I think I've seen the worst values.
I totally understand it's like a placebo thing, but I like telling my patients sometimes when I see their phos is low and they feel tired or fatigued, like so many reasons. But I'm like, remember ATP from like biology? Like, I'm going to replete your phosphate. So you're going to get more ATP, and they look forward to getting their phosphate, whether it's placebo, it makes them feel better. But this is something I do. And tell me why I shouldn't do that.
I love the placebo effect, so continue with that practice. But it brings up this important point about all three of the electrolytes that we're discussing right now. They are largely intracellular electrolytes. We're saying, okay, that serum value is going to be a trustworthy surrogate for what's happening inside the cell. It isn't always trustworthy. As I mentioned with potassium, you can have inward shifts that are transient. Same can happen with phosphorus. And so those don't actually give you a reliable indicator of the total body stored. We give someone phosphorus, we hope that it's being directed into the cell to make all of our ATPs. I'm going to say that happens, because why wouldn't it? If you're going to try to get the patient to take that Nutrifos packet, it seems like a good reason to take it to me.
Similar to potassium, is there a number for phosphate that makes you worried? Like, is there a number that you say, hey, I really need to make sure that this person's phosphate is higher the next time that we check it?
I mean, I think all of us will be very anxious if we see it less than 1. I have many patients who come in with alcohol use disorder who have hypokalemia, hypophosphatemia, hypomagnesemia, hypocalcemia, sometimes with values that are profoundly low. And lucky for me, I've never seen a case like rhabdo from the hypophosphatemia. I feel like I can support it. Is if it's less than 2, let's give a little bit of phos. If it's less than 1, let's do a little bit more fast and aggressive.
What do we worry with hypophosphatemia?
I think we worry about things like muscle weakness. We worry about things like rhabdomyolysis. I'm less aware of cardiac muscle manifestations of hypophosphatemia, where like that 2-hit hypothesis we might think about for hypokalemia. I've got a patient who's post-MI. Well, we got to get that phosphorus up because they're at risk for ventricular arrhythmias. That is not something I'm aware of.